In the following, I will provide you with data from our experience in treating lung cancer and lung cancer metastasis. And we are proud to give you our experience, especially in those indications. If you look in oncology, it's currently clear that interventional oncology is a major part in oncology and will further increase the value of interventional radiology, interventional oncology. What is the role, especially in the education? So for interventional radiology, it's important to define people who have an interest in interventional radiology. We have to see the residency is most competitive as a medical specialty, especially in US. And we offer numerous management options for those patients, and there's an increased role in palliative care. Interventional oncology, also in the lung, has to differentiate whether we are performing image-guided diagnostics, image-guided treatments, subspecialization, multimodality, and interdisciplinary treat. And what is important, it's for the first time also a patient-facing frontline position. You have to deal with the patient, you have to define the role between patient and interventionalist. The development means that we have to understand more on the biology and pathology of disease, on the technology, on the devices, on the accoutrements. We need as an essential image-guided knowledge, and we need procedural treatment skills in order to access, to map, and to perform action. So in lung cancer and lung metastasis, interventional oncology can mean that we first of all have in the interventional service a diagnostic and biopsy arm, which is documented here, and then we have maybe fluid drainages, and then we have interventional oncology by performing procedures, and this can be then divided to vascular pain procedures, especially in that area. So it's important that we differentiate, that we train our people in our departments, and that we direct our imaging equipment in this direction in order to follow the diffusion of innovations, especially in that respect. One of the major goals which I try to push in Frankfurt is to have translational research by defining options, by developing and performing concepts in clinical trials like the SURSI trials, workup, multi-center studies. That is very important in order to find that. Interventions in lung cancer can be performed either vascular, in the angiography, like is shown here, CT-guided, ultrasound-guided, and under certain circumstances also MR-guided. I want to start with intraarterial therapies of lung tumors. I will define with you the definition of those areas. We will define new technological developments. We will define what are the best perfusion embolization therapies, and what will be the future developments, transvenous chemoembolization, transarterial bronchial perfusion, ablation therapies. First way to go, this would make sense, is to perform a transarterial bronchial embolization. So we are accessing the bronchial artery, we are looking at the vascular network, and then we can define whether we can perform here a perfusion of that network or perform an embolization, but knowing that first of all, there is an enormous variation in this vascular supply. Often the right bronchial artery arises from the intercostal bronchial trunk in more than 90%. So it's very important to define that and to look also for this problem. And we have a vascular supply of the spinal cord, especially from the left bronchial artery. You have to be very careful, because if you see it here, then you suddenly have an access to the spinal artery. The risk is a spinal cord ischemia resulting in paraplegia, which is a disaster. This is why isolated lung perfusion was first performed by Poland, published in 2007, and he was perfusing the lung by the pulmonary artery. And he could show that the tissue concentration after this perfusion, for example, for doxorubicin, was 20 to 25-fold higher. So there could be a first pass effect in that. Here my technicians, and I'm very thankful to this great team I have here in Frankfurt. And this was then documented by a recent animal study in horse, where Dr. Barabas showed that using a doxorubicin mixture in transpulmonary chemoembolization by the pulmonary artery has a mild or temporary increase of pulmonary pressure, no pathology to the lung, no ischemia of the brain. This documented how effective this can be. How the treatment is done. We insert the femoral vein, then we go to characterize the pulmonary artery, then we look for the feeders for the tumors, we look for pulmonary arteriovenous shunt, Then we can place a balloon catheter into the segmental artery, and then we are injecting our drugs, mitomycin, gemcitabine, cisplatin, irinotecan, doxorubicin, and we can embolize lipidol as a permanent embolization material or microspheres like Embocept S as a temporary agent. Here is again shown it's a percutaneous procedure. We have a local regional drug application. It's selective and it can be performed bilateral depending on the extent of disease. Here you see a typical angiography. We are inserting the pulmonary artery. We are injecting the contrast, and we see quite early a transgression of the contrast medium into the venous outflow, which is documented here. And this is important in order in certain tumors to look whether there's a shunting, because if you have early shunting, it might be a problem. The drugs, embolization material, whatever, what we are injecting into the pulmonary artery is transgressing into the pulmonary vein and causing us major complications. So the stark microspheres, which are degradable by alpha amylase, are the solution, because these are hydrolyzed stark molecules. We have a diameter of about 50 micromole, and the half-life is at 37 degrees, about 35 minutes. And we have an enzymatic degradation by the amylase. So using that contrast agent, we are quite on the embolization material, we are quite on the safe side in that respect. A recent publication underlined that we have the two possibilities for vascular treatment in lung cancer, bronchial or pulmonary artery. They performed a phase 1 clinical trial, and they could show that especially in lung metastasis, there was a high rate of tumors fed by the bronchial artery, lower rate with the pulmonary artery, which is documented here. And what they could show is that CT angiography, a CT scan before, is helpful to define anatomy of bronchial, non-bronchial arteries. Bronchial angiography and pulmonary artery is essential. They have been using mitomycin Z-power lipidol as a contrast agent, and it was followed by Embocept S. And the lung chemoembolization was documented here also with ethionized oil retention, the technical success rate, and the PET response showed a partial metabolic response in 40%, stable metabolic disease, and the progression only in 10%. So they proved also that here this technique is effective. And interestingly, the blood release of mitomycin after taste was 45%, half-life of 2 minutes, slow release 55%, more than 5 hours. So it shows that this is effective. We can achieve first pass documentation, and here an example of lipidol placed in the pulmonary lung metastasis after the bronchial artery access, very nicely demonstrated. If we go to the second goal we want to have is to destroy the tumor, and this is only possible by ablation. We can do it chemical, we can do it by radiation, ischemic, by thermal techniques like RFA, microwave, laser, or cryotherapy, by reversible electroporation of focused ultrasound. These are different technologies we can use. They are documented here. I think in the lung currently, the major experience is on microwave ablation. How does it work? We have the dielectric heat loss with the different fields, and the heating shows it in the complete penetration depths. We are avoiding tissue carbonization. We have no restriction of the distribution microwave to the tissue, and we have a significantly reduced heat sink effect. I think that's a very important aspect. With a microwave ablation, what we want to achieve is a round lesion. We want to have a round lesion with an equal diameter in the transverse and sagittal orientation. We call it the roundness index, and here you see the Mona Lisa in an oval-shaped thermal ablation, and here in a round-shaped. So the roundness index is long to short is 1. And this is a measure, this is a goal. We want to achieve precise, predictable ablation zones. That's important. And here, for example, Amplin technology documented the active part after the ablation, the passive part. This is a tumor, and this is a vessel, for example. So we have to pre-plan this. We need a good field control in order to define that. So we need sufficient ablative margins around the lung lesion, reduced local tumor progression rate, few complications we want. We want to have as high safety to do, and most likely in the lung, a single antenna use. And currently the rule is about 3 centimeters in diameter. That is respectable to do. Here, an example, lung metastasis, a 70-year-old male patient from unilateral lung metastasis. He underwent 3 cycles of chemoembolization, and then he was followed by thermal ablation, and still he is free of disease. You see the CT angiography before the treatment, one lesion here, one lesion in the middle field, and then after treatment you see a downsizing of the larger tumor here, and then we see also downsizing of the tumor in the right lateral recess. After thermal ablation, we ablated all 2 lesions. During the procedure, there was a minor pneumothorax, no problem. We are immediately evacuating this, and you see the immediate scarring after the ablation. In the follow-up, it was completely resolved. Another patient, huge recurrence of lung cancer, locally infiltrating, a good indication for performing TACE, injecting via the transpulmonary position catheter into the lower pulmonary artery. We see access the inferior lobar pulmonary artery, and interestingly, if you see then after 4 TACE, tumor significant lower in volume, devascularized, homogeneous, so a good result in that respect. Another example here, after the 5 TACE, positioning of the catheter, quite an easy maneuver. After 6 TACE, we see here a further downsizing of the tumor, and thermal ablation was finally decided in the tumor board. We have been using a Medtronic system here, applying an energy of 10 minutes, and in the follow-up, the tumor was constant and no further metastases. Another case, dyspnea, loss of weight. The patient detected this parahilar tumor, which is nicely demonstrated in MRI. Patient refused to undergo a systemic treatment or radiation. I biopsied the tumor here, which is demonstrated here. Then we went into the tumor board. As you see, radiology, pneumology, oncology, surgery. And the question was whether to resect, whether to perform external radiation or interventions. Finally, the patient and me decided to perform a regional application. I inserted a catheter into the pulmonary artery. We performed an angiography documenting in cone beam CT the hypervascularization of the lesion. Here, the CT follow-up showed already after 2 cycles of downsizing. Finally, we decided to perform a thermal ablation, which is documented here. You see the heat loss, the vaporization, and at the very end, the follow-up showed the scarring, but the tumor was completely ablated. In the PET scan, follow-up also 2 years later, there was still always a slight uptake of FDG. However, CT scan and MRI showed that there was no recurrence, and the patient now is a further follow-up now 1 year again later, no recurrence, so complete ablation. So for the cancer and primary lung cancer, it can be summarized that if we have stage 1, surgical resection is the standard. We can have also, if it's not possible, we can use stereotactic radiotherapy, microwave. And then, of course, if you have central tumors, we have to discuss whether these patients are a good candidate in a second-line treatment or also for the stage 2 lesions, also stereotactic radiotherapy, lobectomy might intention. Let's look at our data. In Frankfurt, we have treated meanwhile more than 300 patients, chemoperfusion and chemoembolization. You see maturity lung cancer, colorectal cancer, breast cancer, lung metastases, and sarcomas. And you see this, the estimated area of survival, best in the colorectal cancer and the very best in the breast cancer, while in the lung cancer and others, the prognosis was much poorer in comparison. Our data published in 2019 showed that this method can be performed with 100% technical success rate, partial response 11%, stable disease 66, and progression only in 21, survival 30 months in neoadjuvant and ablation group, I think this is respectable. And the final slides will show you that even that statistic and artificial intelligence is helping us, because we saw suddenly, okay, here survival is better if we have, of course, a partial response in comparison to stable disease or palliative. Kaplan-Meier showed also that if you have patients with a unilateral disease, survival is much better in comparison to unilateral, to bilateral. And here an example of the ablation in the patient, colorectal lung metastasis, the liver was clear, 3 lung metastases, 1 to the heart, ablation, 1 centrally, difficult to ablate. You see why this lesion is always moving, you hit it like a nut in a champagne glass, and finally, in that result, I managed to address all these tumors, and I had been lucky to control the patients 2 years after these 3 microwave ablations, and we had an R0 ablation. Tumors were completely destroyed. There was no recurrence, and patients were tumor-free. Also, combination is important. You see the lesion itself, performing chemoperfusion, embolization, and finally then ablation. Let's look at the lung tumors till 1918. You see in the therapy session, we started with laser, then we went to RFA, and finally now we're doing most of the cases with microwave. And you see in the mean 2 sessions, overall survival 6.8 years. So this is how we go into a tumor board with lung. And we can offer now transpulmonary chemoperfusion embolization. We can offer transvenous access. We can use a transarterial access depending on size and volume. And this is a treatment decision. Patient goes after our imaging, the multidisciplinary board, primary surgery, local regional therapies, chemotherapy, or then also radiation, which can be performed, and here are the techniques. I'll show another example that also if patient have already a lymph node metastasis near the hilus, we are able to inject drugs there to improve the situation. So there's always a chance. And before and after ablation, you see, and this is the advantage of microwave versus stereotactic radiotherapy. We have only minor scars. We can take during the procedure a biopsy. We can prevent tumor cell seeding documented. And here in comparison, again, we see that the embolization is a little bit better than perfusion because we have a more permanent outflow of the drug into the lesions. In summary, TASTE for lung tumors is feasible, safe, and repeatable. It has some advanced potentials, especially if we are able in modern oncological therapeutic concept to bring the technology to an area that we can perform also neoadjuvant and afterwards the ablation in that respect. The way where to go might be MRI in the lung, not easy. Goes for the future, active research programs, platforms like radiomics helping us to get our data evaluated. And anybody who's interested in research is welcome in my department to perform research here. Open form platforms are documented here. Finally, I thank you for your attention. I wish you a wonderful meeting. Hopefully in the next years we see us in person. And if you have interesting cases or want to get more information, don't hesitate to stop here in my email or call me, or we do a chat in order to help you, assist you, and or assist your patients. Thank you.